The interesting thing about a community hospital is we all live in the community. We have expectation that someday we may have an urgent or elective need for care, and we want to be able to know that we have full confidence that our loved ones will be able to get it here. I'm Seth Bilazarian. I'm a clinical and interventional cardiologist at Lawrence General Hospital. I've been the medical director of the Cardiac Catheterization Laboratory, and I'm the co-chairman of the Cardiovascular Steering Committee. We have really committed staff that are really enthusiastic about constantly evaluating and reevaluating best practices to make sure that all of our patients are getting the best care. We always are willing to discuss and review new practices, new technologies, whether they fit in, whether they be additive in value, both for clinical value, but also for our goal of being good stewards of healthcare costs. I'm always delighted when I see patients in follow-up and I say after their visits at Lawrence General Hospital, how was your care? And patients have uniformly been very delighted in their care. They're delighted from the treatment early in their care. They are delighted with the way they're treated before, during, and after their procedures. They're delighted with the short length of stay for their elective procedures. We can't take care of patients who have heart attacks until they call us. Call 911 or come to the emergency department. But many patients unfortunately wait a long time, and they suffer huge consequences, including death, by waiting. And we're really excited of going forth about strategies we're going to undertake to have partners for chest pain, employers, community organizations, churches, other organizations to really help get out the word that if you have chest pain suggestive of a heart attack, that activating 911 and coming to Lawrence General Hospital is a best practice to help not only save a life, but reduce long-term problems like congestive heart failure or other problems. The cardiac catheterization procedure, many people recall, was traditionally done from the artery in the groin, and patients remember having to have a sandbag placed on their groin. It was quite uncomfortable, had to lay flat for a long time. For many years, the procedure has been done from the wrist artery. In other countries, in Canada and France, have been doing these procedures for many years, but the United States was a late adopter. Our laboratory here at Lawrence General Hospital, thanks to only having 3 interventional cardiologists, was able to adopt this very early. We've been a radial-first laboratory for more than 5 years. Patients get the procedure from the wrist, they're able to sit up immediately and have a comfortable wristband put on, and the risk has been shown to be dramatically reduced, even to be life-saving for the emergency type procedures called STEMI angioplasty. So we're very excited to have been leaders in this, and I am a physician on staff at many academic medical centers and tertiary care centers in the Boston area, and they were very late to adopt this procedure, in part because they're larger organizations and didn't necessarily feel the need to take this on. But we were very excited that we were leaders in this, and they're finally catching up with us.